would like to turn this over to Dr. Mike Liu and Dr. Paul Casey to bring a different perspective on the application of data science and machine learning into healthcare. And really the perspective is that of practicing docs, informaticians, educators, operational leaders, and where they are on this journey. Much like this conference, Kensai, we've been on a 3-year journey to prove out the thesis that doctors, data scientists, and software developers working together could do something incredible and actually impact human lives. And it's a work in progress. I think we've learned a lot, we've done a lot with math, we've published some really cool papers, but I think we're still learning the hard part of applied machine learning in healthcare is still healthcare. And I think that some of the challenges on aligning to strategic priorities, understanding organizational maturity, and getting stakeholder buy-in and really showing how we can move from data to intelligence to value is very much a work in progress. So I want to turn it over to these guys. The format's going to be 5-minute TED Talks each, really sharing where they are in their journey and their institutions and roles. We'll do a few questions with them, and then we'll turn it over to the audience. We'd really like to hear where you guys are in your journeys and where you see there's opportunity, both in the near term and the distant future. So thank you very much. I'll turn it over to Paul.
Yeah, I think so. Thank you first of all for the invite. I'm really excited to hear all the stuff that's going on from this group, incredibly intelligent group. So I can talk a little bit about, I'm from Rush University Medical Center in Chicago. It's an academic medical center right downtown Chicago, part of a larger health system. And I can speak a little bit about my role, how I got involved in the current informatics and AI work that we're doing, as well as where we are, where kind of Rush is on our journey overall. So I began, as you can see, I have a couple different directions that I go in, and I began really in emergency department operations. And that's where I started to see that really so much of that relies on having good data, having reliable data, actionable data, which is what got me involved into the informatics side of things a few years ago to really start trying to create that data lake that we had better data to be able to make some operational decisions upon. From there, I also became involved in some patient safety initiatives and took a role in the CMO office as senior patient safety officer as another opportunity of a place where we're a little bit data poor at times, but I think we've made some nice strides in the right direction. In terms of where we are in our AI journey, we actually partnered with Greg and Kensai a few years ago, and we realized that there's so many opportunities. I think sometimes the temptation is, I think when Greg and I first met, I probably stressed him out by the 10,000 different applications of potential ways to bring artificial intelligence and machine learning into the healthcare realm or into specific applications that we talked about. But we decided, let's choose something that's easily operational, something that we can get good data around and truly be able to move the dial on. So we developed a prediction machine learning model for prediction of patients that are going to go on to be left without being seen from the emergency department. For us, that was valuable because we were able, from the minute a patient walks into the emergency department, to be able to tell, what's the likelihood on this patient leaving before seeing the physician, which obviously not just has revenue implications, but also medical legal implications. And we went that direction importantly because I knew that if we were able to create a model, an accurate model around this, there was already the ability to operationalize it essentially overnight. And that has stood true that in putting this in, it became the first model that at Rush we put into we're an Epic institution, and we built it into the Epic cognitive computing platform and went live with it and pretty quickly saw the ROI on being able to better predict that for our patients. So I think that's one small example, but it was one small example to allow us to kind of establish the confidence that we can do this well and know that we can build on that from there. So I'll turn it over to Mike for.
Okay. Thanks, Greg, Kensai, and to the organizing team for the invitation to speak here. Very interesting. So my name is Mike Liu, and I am from the University of Washington in Seattle. And I got to say, these lights are really pretty astounding that we have on us. So where we are in our journey, so how I came to AI, I guess, was probably when I trained in computer science. Mm-hmm. So I'm actually a computer scientist by background and a reformed software developer after 8 years in the field. Yes. And so after that, I went to medical school and trained in pediatrics, and then after fellowship, went to Seattle Children's Hospital, where I've been an informatician since 2007. So, and I also have an affiliation with the University of Washington. So at Seattle Children's, there's two things that we're doing with AI in medicine, and neither of them really have much to do with medicine. So one of the things that we're working on currently has to do with predicting flow in our emergency departments so we can understand what are the peak times and are there going to be enough providers so we can actually call more providers in to work with patients if it's needed. And the second thing that we're doing with our AI actually has to do with working with a company. It's kind of like the presentation last night that had to do with phishing. We're actually working with companies to understand better when it is that people are unauthorized, have the unauthorized viewing of charts. And so we're actually applying artificial intelligence to see what are the patterns of the chart access to see are these people accessing charts that they shouldn't be. So those aren't really medical AI applications at the hospital. But also I work as the fellowship director for clinical informatics at University of Washington, and I started there in 2015. And I would say that the University of Washington is a pretty large healthcare system where we have an academic medical center, a trauma center, and 2 community hospitals in addition to a number of clinics. And I'd say that we're also very early on our journey with AI there, and our journey there is complicated by the fact you might have heard that we just are investing $180 million in going to Epic. So that is probably going to be our largest priority in the near future, although we are looking at some applications of AI, such as trying to predict readmissions and also trying to understand who are our high utilizers so that we can work with case managers with them prior to them developing complications.
Excellent. Well, thank you both so much for sharing that, and really, I think this is just a few questions to continue the conversation. So given your respective roles, where your organizations are in terms of their analytic maturity and what they've done to date with AI, I'm very curious, where do you see the next exciting opportunities, maybe on 2 time horizons in the next 1 to 2 years near term, and then 5 to 10 years out if you're willing to speculate that far?
Sure, I can start. So I think, in the short term, I think there's really some practical applications of AI. We're in the era that we talk a lot about physician wellness or clinician wellness, I should say, both physicians and nursing team and all ancillary staff as well. And I think there's a lot of opportunities to decrease the cognitive burden that's on clinicians and try to make the workflows easier. I know everyone's familiar with the introduction of EMRs. Of course, we've added a layer of complexity, and it's probably, if you talk to any physician at Rush, the most common feedback, although I think we've made great strides, is everything gets blamed on the EMR. Every issue that comes up, if we could just do it better in the EMR. So I think we have the ability to, in the short term, leverage AI for some of those types of, try to make the workflow a little bit easier, even the, ambient listening to help with note dictation. We're really focusing efforts on making sure that clinicians are only in the EMR when they're at work. And as a lot of clinicians, if you ask them over the past 5 to 10 years, you're at work and then you go home and you do all your documentation afterwards. And that's really, not a formula to be have a really great medical career and spend more time with patients, which is ultimately what we want clinicians to do. So I think those are some of the short-term fixes that are kind of in works, and there's already partnerships. I know, between Nuance and Epic, some of those types of partnerships I think will have relative short-term results. In the longer term, one of my more recent passions, I think, is the impact we could have on patient safety. So I know one of the speakers referenced earlier, we have good evidence that in the U.S. healthcare system, medical errors are the 3rd leading cause of death behind cancer and heart disease. Per the BMJ article, over 250,000 people die as a result of medical errors in U.S. hospitals, which is just astounding, right? And if there's one thing that we can promise patients is that we're not going to harm them when they come into a hospital. And then I think, that's the big picture, but there's some very practical things we can apply AI to. There's, for instance, C. diff. C. diff kills 30,000 patients a year in the emergency department. It's relatively there's factors that seem like should be predictable around the development of C. diff and the treatment of that. And there's about $5 billion in cost savings, if we're able to reduce that. So there are practical things like that. Similarly, CLABSIs, CAUDIs. We're doing some work currently on falls. So years ago, we had a sentinel event of, like most hospitals, when a patient comes in, we do a fall prediction based on a static scoring system. So that score is done once or twice a day, depending on the floor, but it remains static. And there's a lot of things that happen. We work in these hyperdynamic healthcare institutions where the factors that change the risk of fall change almost hour to hour based on what medications we're doing, what the the patient's status is. So we had an event years ago where a gentleman was in our ICU on anticoagulation. He was scored as a moderate risk using the static tool. Subsequently went on to get a few medications. He was having difficulty sleeping, so he got Benadryl, which increases the risk of falls. He went on to fall and had a bad outcome as a result of his falls. So there's stories like that really, in my mind, those stories are the ones that inspire, like, we can fix this. This is something we should be doing better on, and we can predict this and do a better job at, moving to use AI for some of these types of things.
Absolutely. Mike?
Yeah, so I'd say that AI feels like it's at the point where it has a lot of potential, and I certainly think that in the short term, it might be harder to realize the potential than in the really long term. But I think that, so one of the things that I have done at Sailtrons is I helped to found our clinical effectiveness team. And so that is actually a team that has created over 70 clinical pathways, and over half of the patients at our hospital actually are on a clinical pathway on any given day. And so that is kind of like the epitome of kind of like evidence-based medicine. And so we have sort of figured out that, like, how do you get clinicians to practice similarly, and how do you measure that using data to sort of see how it is that you can actually affect clinical outcomes by standardization of care. But I think that even with all the sophistication we have there, it's still difficult to understand, like, how AI will help us with our journey, because that's kind of like the operational, how do you make it happen part. And the AR is kind of like, well, how do you change the face of medicine and tell us how to do things that we don't even know about yet. So I think that that's the thing that's a little bit challenging, that I think that there's a potential for those data sets to tell us things about medicine that we don't know about, that we could learn from and we could get better outcomes from. But if only we could figure out what is the truth, and then how can we encode that truth in a way that people would practice it. I think it's the question. But I do think that I'm a very optimistic person naturally, and I'd say that probably 5 to 10 years maybe, or maybe 20 years from now, I think that one of the things that's really amazing with AI is that there's a lot of technologies that improve the perception of the care team. And so I've seen some studies where they talk about, like, helping radiologists read the x-rays better, or perhaps people that can actually analyze the gait of patients so that they can actually figure out what is the problem with the patient, probably even more than maybe a non-specialist clinician would be able to do. I think that AI has a lot of potential for us to sort of augment the clinical reasoning and really expand it in ways that we can't foresee yet.
Oh, excellent. And I think that's certainly some of the work we're seeing in this conference, is that possibility for augmenting intelligence and doing better clinical decision support. So I'm curious, thinking about those two time horizons and some of the practical applications in the near term and some of the distant vision, where are you in your process of sort of measuring the impact of AI? Knowing that it could be so grand, and then knowing that we're trying to make these incremental changes. What have you learned so far in trying to capture that process as you roll things out?
Yeah, okay. So I think that one of the things that's really challenging about AI is kind of like, AI isn't like a comprehensive system that you can put in. Mm-hmm. So let's say that I was successful at one of the AI projects that's going on in our institution that's in a research base. One of the things that we're looking at has to do with, like, trying to understand if a patient should be admitted for a particular diagnosis, or even some of these sepsis prediction algorithms that one of my fellows or graduated fellows who's in the audience actually was working on. Yeah. So let's say that even you managed to perfect the AI because you've solved all your data issues that you had and you understood the clinical stuff. It's like you can't really evaluate, like, how do you take that number and operationalize it until you understand what is the intervention that you're going to do. And then when you actually take a look at the intervention, you want to compare the future state with the intervention and the past state without the intervention, and see, so what is the impact of doing that intervention. So I think that a lot of the times people work on these AI projects, and it's very challenging because since they're not thinking about what's the intervention, they're just doing the project. Then it's like you bring it to the healthcare system and you think about it, it's like, well, so let's say even if you were able to compute this perfectly, is there some impact to clinical care? And if the answer is no, then it's like, was it a wasted project maybe even? It's like, how do you prioritize these projects up front so that you focus on things that even if you were to be successful, then you could operationalize them in some meaningful way. Definitely. So I think that we have some tools to do that, where we take a look at value analysis for our interventions related to pathways. But for AI, it's like we're not even to the point where we have the interventions that go with the AI yet. So,
I think just to add to what Michael said, I think the temptation sometimes is to apply AI to where you have the data. as opposed to looking at the clinical problem that you're trying to solve and define that metric from the outset. Be able to say, here's what we expect to be able to solve, and here's the reduction, in whatever metric, whatever, whether quality, safety, et cetera, that you're looking at. You got to define that before you start trying to look for the data even, to really be able to figure out where the biggest opportunities are for that return. So we similarly try to prioritize. I mean, the challenge is, again, that temptation to kind of boil the ocean. We have a pretty, we established a governance over the past 5 years or so that now any ideas, there's a lot of ideas that come up in terms of where we can apply machine learning, but that comes to our data governance committee, which I sit on with our chief analytics officer as well, and we really score all these, and that's one of the key things we look at is are we actually going to move the dial by doing all this work, because you really can just prioritize 3 or 4 things to work on that you're going to move the dial on before you start trying to work on 30 different applications simultaneously. And I think that approach has worked fairly well. I mean, I can speak to our left without being seen model. We were able to see a significant reduction in our left without being seen by having the data out there, from the outset.
Great. I was smiling because it's a good lead into the next question, but if I can sort of summarize that, it sounds like we need to work from the solution backwards to the technology and not start with the technology first. And so I heard the G word come up, and I think that's one of the next question is lessons learned and challenges that we've confronted. And I think one of our learnings together has been how important governance is in this new world. And most folks are thinking about data governance, but you also need to have the model governance and almost a process and a transformation governance team that's really working on things as they move beyond projects to the real world. So extension to the question, just what have we learned along the way and challenges confronted, and what do you see coming up next that we need to focus on?
Yeah, I mean, I can speak a little bit to the challenges. I think everyone in this room buys in, obviously, to AI, or you wouldn't be here. And it's easy for us to say, here's the problem, we can use AI to solve it. The challenge is often getting the clinical team to buy in, right? Yes. So, this is something we learned over time is as we deploy these different models, you need to have, the clinical teams have to have trust with it because this is all relatively new. And when you project a score, within your track board to say, here's a patient's risk of X, Y, or Z, the clinical team also needs to know what goes into that score. So I really think one of the learnings is complete data transparency. You really need to, for every model we develop and deploy to a clinical team, we need to be able to show them what are the factors, what are the variables that are, supporting this model. Because just putting a number in front of them and saying, no, trust me, it's validated, doesn't work. We're naturally inquisitive in healthcare, and they won't trust something that they don't, completely understand. So I think that was both a learning but a continuing challenge, again, as we think about future models, is how are we going to get this to the clinical team at the right place in the clinical workflow that's actually going to have an impact, and let them know what the data is behind it so that they trust the model. And I'd say the one other piece to this that we kind of learned through time is it's also any model we develop and deploy has to outweigh kind of clinical gestalt, right? Mm-hmm. So if I'm an emergency physician by training, and as an emergency physician, if you show me if a 90-year-old diabetic with coronary artery disease and chest pain comes in, and you show me that the model says that this patient might be having a heart attack, that's useless to me and it's probably going to annoy me if you pop that up in front of me. So it's really figuring out the things that are going to outweigh that clinical gestalt so you can actually, it's useful to the clinicians and not just information that they already kind of knew.
Yeah, so I think that when you talk about the challenges, they're numerous, so I guess we'll just pick one or two. I think that the question about clinical gestalt is actually something that I've been thinking about a little bit, because I also wonder if that's something that artificial intelligence can help with, augmenting our clinical gestalt, or it can identify things. But I actually think that probably one of the hardest things for us to think about as we try to get these interventions into healthcare is just there's this phrase that this orthopedic surgeon shared with me once that I really liked, which was coin of the realm. Mm-hmm. And I feel like the coin of the realm in hospital systems and the coin of the realm here in this room is not at all aligned or the same. So I think that one of the things that is valued in our healthcare system at the University of Washington might be for our faculty publications of the coin of the realm. And so they want to innovate and they want to publish on these things. If you take a look at kind of in the hospital, it's like the coin of the realm is really how well do you align with our hospital's strategic priorities. Mm-hmm. If you don't align with the hospital's strategic priorities, you're probably not going to get any money because you have to displace things that are strategic priorities and you won't ever be able to do that. Mm-hmm. So Whereas compared to here, it's like the coin realm might be money, or it might be ideas and innovation, but it's like they don't always match up. And it's like if you don't communicate to a hospital kind of like in the language that they can understand, then it's really hard to get funding to do those types of projects.
Well said. So I think the obverse of that question is, given the early successes, incremental as they may be that you've seen, are there some pearls that you could share with other folks, lessons learned that have been positives maybe, or maybe it's pitfalls to avoid?
Yeah. I mean, I think I can speak a little bit to kind of touching on some of the things we've discussed. That operational alignment, and Michael's exactly right. Trying to find the opportunities that are easily operationalizable, if that's a word, that align with the strategic priorities. Because again, you can create a model that kind of in a corner that doesn't align with priorities, but you'll never be able then to scale it and really ultimately impact healthcare, which is what we want to do. So I think those are the two most fundamental questions we now have. Any model that we consider, we say, what will be the operational impact? How easy will that be to get into the clinical workflow? And I think that's where the other piece is integration. So the ability to integrate, in our case, with the Epic Cognitive Computing Platform has been huge, because there's a lot of systems out there that say, we can present the machine learning tools, but you just have to link to a different site or to a different place. And so it has to fit well within the clinician's workflow to really be effective and be able to drive to some of those outcomes. So I think that's the lens we now view any potential machine learning opportunities or AI applications through, that seems to have served us at least well to this point. And then the final thing I would say is just that, back to, there's so many opportunities out there that every single day I see, 100 different ways we can apply things. You have to be patient in all these things, because I think, especially as emergency physicians, we want to see, the results the next day. And I've realized, you got to be a little bit patient, make sure the data is exactly where you want it before you consider deploying it to the clinical team, so that they trust, again, what's being presented in front of them.
Yeah, I think that one of the things that has been really positive with these types of projects that we've been able to do, even if they're small AI projects versus larger hospital operational projects, I think that some of the things that allow you to be successful really relate mostly to kind of solving something that was kind of a problem that I learned about in fellowship, which was kind of like the investigators come, they bring all their money, they do their intervention, they leave, and then everything goes back to the way it was before. And I think that one of the things is kind of like the promise of health information technology, and not just AI, is really the idea that if you can actually design the workflows in such a way that the automation reinforces the appropriate workflow, then you can actually sustain things for a much longer time. So I think that one of the challenges for our field is really to understand, like, what are the interventions that we are doing, and how can we instrument them in ways that we can understand if we're backpedaling on what we were doing, so that we can actually sustain the gains that we have. And I think that hospitals are becoming more apt to, through improvement in science, do things like more rapid cycle improvement. I don't think anything with technology is rapid cycle, but I would say that more rapid cycle improvement, and so they are open to piloting things and simulating things. And so if you start positioning things in a vocabulary that hospital personnel can understand, then you might be more likely to, oh yeah, we would do a pilot with you, as opposed to, well, do this intervention, and the AI, it's like, oh my God, it's so complex, why would we want to do that?
Absolutely. So I'm hearing workflow is important, and yeah, definitely. So thank you guys so much. This has been a great conversation. I think, as we mentioned, it's early yet. I'm really excited to see where we'll be next year, and perhaps even 5 years from now. I hope it's still at the same conference. This is a wonderful place. I want to open this up. We've got a few minutes, and we're actually running ahead of time just a bit, so we can take questions from the audience. And really, again, would love to hear, in the similar theme, where you guys are in your journey, given your technological maturity, your respective roles. What have you learned along the way that you could share with everyone here, so we're at least making, interesting and new mistakes together, and have some learnings next year to show.
This is a quick question for Dr. Casey and Dr. Liu. You talked about your short-term initial projects. Can you give us some more detail about that? Like, how long did it take, for example? And with respect to those projects, are they still up and running? Are they part of your kind of dashboard that you have for your hospital systems right now? Thank you.
Sure. So I can speak a little bit to it. So we do some of our short-term projects. I think the thing obviously that takes time is the new ideas that don't already have any sort of data around them, right? Because that's your roadmap then becomes defining the data, starting to see is there actually kind of a there when you look into the data and how you're going to be able to how you're going to be able to move that dial. So those become the little bit the longer term 6 to 12 or even 18-month type projects. We in the short term have been able to use, I think it's one of the things that some of the big EMR vendors are beginning to have some out-of-the-box type machine learning models that you can at least apply the data to your institution and make sure that the data stands or the model still valid at your institution. And those become some of the shorter term ones. So for instance, the prediction of capacity within the emergency department, that was a EMR supplied machine learning model that stood up to the test when we looked at it, and we're now able to better predict staffing and predict volumes within the emergency department at the beginning of the day. I think the other piece to that is the sustainment, the sustainability, kind of like Michael was talking about. So we actually tie that information into we have a daily readiness huddle in the emergency department at 7 a.m. and about 100 different locations throughout the hospital. So we tied that model directly into an operational huddle to make sure that it would continue to sustain and we'd be able to continue to build or learn from that. So those are some of the shorter term things we've been able to implement. And when I say shorter term, those are in the kind of 6 month, 0 to 6 month, anywhere from the decision to move forward to actually deploying it clinically.
Yeah, I'd agree. I'd say that for example, the ED flow prediction model, I feels like those projects are usually like 6 to 18 month projects. And so I would say that usually, but I think that one of the things that is different is that was actually developed by our I don't even know what the right word is. I guess our data scientists inside of our own IT department. So I think that things are actually resourced by the hospital. They are usually in response to some kind of hospital goal. So I think that particular goal probably related to throughput in the ED and length of stay inside the ED, so you could follow those higher level measures, and this was one of the interventions that the executive said was okay to research to do that. But I would say that what is funny is when I talk to data scientists, they usually say, oh yeah, we could build that in a week or something like that. So it's not really like that, it's more they build it in a week and then it takes a long time for them to get buy-in and then to pilot it and then to actually be able to use it and then they have to show that it made a difference. Yeah. So it's kind of even though the technical work might be to them easy, or to people in this crowd easy, the actual making it actually happen takes a long time sometimes.
Indeed. I can kind of share an anecdote to align with that. When we were developing this left without being seen model, I was invited to a meeting of our hospital executive team, and our CIO said, today we're predicting left without being seen in the emergency department about a month before we were really ready to go live. So obviously everyone in the room got very excited with that idea that we'd be able to, it was the first time we were able to predict something like that. But sometimes those are the things that speed up the implementation. Is now we got to get that thing in there, and for next month's meeting when this comes up again. So sometimes just that continuing to drive things forward and try to accelerate the pace as much as possible is really driven by the leadership.
Excellent. Great question. Thank you.
Thank you. Question with regards to when you implemented this, was there an increase in the percentage of false negatives in terms of who was going to be admitted to the hospital? And did that in any way result in patients who usually may have gotten more attention but sort of were put in the less acute? For example, someone who comes in and says, you know what, I think I ate something bad and I got a stomach ache, but then they forgot to tell them that they actually have a shunt and hydrocephalus and a bowel perforation, etc. Did you find, and how did you account for those patients?
It's a great question. This is specific to the left without being seen model, I assume, yeah? It's specific to the left without being seen model? Yeah, so it's a great question. It's one of the things, actually, I think when Greg and I first met, it was one of those things we kind of had to think about is how, we don't want this model to bias the team to pull back patients that have left, from the ED 7 times before and thus are, higher likelihood this time. Fortunately, within the way that we operationalize it, we have kind of like a lot of other institutions, a provider and triage role. So a lot of preventing that type of bias and that type of error was in the way that we rolled it into operation. So we told the clinical team, use this model only if you have 4 patients, all of the same severity based on our initial assessment by our provider and triage. They're all kind of in the same priority. Try to prioritize then the person that's more likely to leave, but don't use this to drive, because someone came in for a medication refill to the emergency department, but they're very likely to leave without being seen. That patient should not get priority over someone that's more, has a higher medical necessity for being the next patient to be seen. So we're continuing to kind of monitor that as a control, control variable within what we're looking at. And on a day-to-day basis, I'm going back and looking at the patients that actually did end up leaving, what was the score prediction and what was the underlying medical condition. Thus far, we haven't seen the.
Is it always a provider/physician who's evaluating them so that you know that information is accurate versus someone at the front desk or perhaps one of the nurses who may not be as experienced in every single different entity in the ER?
Yeah, so the model, we populate a score based on the variables that ended up, weighing heavily in the model. The score is actually calculated right after the patient walks in and gets registered. So at that point, it is just the nurse and the registrar that have seen the patient. But as part of our operational flow, the patient then goes directly to the provider. Our provider and triage role. So it's really the provider then is able to already kind of add their clinical input at that place right after the patient has come into the emergency department. If we have days, as all emergency departments, where we have a number of patients in the waiting room, that's where we start using the score to say, well, who should we bring back, of patients of the same acuity, who should we kind of prioritize bringing back from there? Does that answer the question, I hope?
Yeah, I think it's the semantics of who are you going to miss, because this gives you a less acute picture, theoretically. How do you count that?
Yeah, it's a good question.
It is. And I think, to abstract it a little bit, I think in the way that you asked the question, there's the seeds of the answer, which is you have to check the counterbalance metrics to make sure you're not generating unintended consequences. So watching to see, are admission rates changing? Are we missing patients of a certain type? Have the distributions of the patients changed to the point that maybe the model's not even performing well? And that really is something that becomes one of the primary inputs to the model governance aspect of this, where you're bringing the stakeholders back to the table and saying, is this performing as we intended it to in a persistent way so we can maintain it safely?
Thank you for the insights. What are your opinion about how you can reduce number of the people that need to be readmitted to the hospital after they get discharged? And when they need to come back, what's the way that we can make it more smooth and continuous from the point that they can, with less number of people in emergency room, everything would be ready for the whatever they need to be happen?
Yeah, so Seattle Children's does actually have a whole project where they're partnering with the insurance company to look at this particular issue. And I would say that it is interesting because I don't know that predictive analytics plays the biggest role in that intervention, although it does play some role in that intervention. So I think that some of the research they've done internally to our hospital does suggest that readmissions may be related to a number of things, including in a pediatric hospital, kind of like parental preparedness to go home and take care of their child in the home setting. So it's like, I think that some of the things that we do in our interventions are not just models to try to predict who's going to be readmitted, which we've done some of that, but it's actually mostly doing things to make sure. It's like, have we asked the families, are they ready to go home? Have they had their questions answered? Sometimes do we have them do teach back and make sure they can actually execute the care plan at home? These are some of the types of things that we do, or we make sure that the medications are right and the labeling is correct, and we do the teaching to make sure that everything is there and they understand what they can call and who can they call and can they call instead of coming in. There's just a lot of different interventions, and not all of them relate to AI per se.
Definitely.
We do have a couple different layers. So we actually have deployed a model too for predicting readmissions for our hospitalist team. And we use that so that our case management team, if the likelihood of readmission is high, the case management team really focuses on those patients. We conduct a social determinants of health screening to try to, connect them to the community resources that are necessary to at least help with some of that angle, as that's often one of the many drivers of readmissions. The second piece is, often it's too late. By the time the patient presents back to the emergency department, it's too late. So we have really been trying to drive more ideas toward, the model of providing healthcare at home for those kind of connecting some of using our technology to be able to monitor their health better at home, and then connecting resources to their home so that we're actually intervening before they come back to the emergency department. In those cases that they do end up back in the emergency department, it's difficult to necessarily streamline the admission. We still do the same process for anyone else presenting to the emergency department, but we make sure that our case management team, actually on the dashboard they use, has that predictions model as well for readmission, and those are the patients that they're targeting for the social determinants of health screening, even within the emergency department. So we're really trying to hit that kind of at every angle throughout the hospitalization based on the data.
I'm afraid that's all we have time for. Thank you very much to our panel.
Thank you.